Healthcare Synergy is more than just a software company. This year, we are proud to roll out our managed services tailored to an individual need for home health, hospice, and other post-acute care providers. These services are broken up to what we call the ABCs of managed services: accounting, billing, and clinical. While the Healthcare Assistant series of software solutions offers agencies a solid foundation for billing of services, this financial component is only a fraction of the true financial health of your agency. We supply agencies with a certified public accountant to assist in the management of the agency's financial assets and liability. Besides the knowledge and experience that the CPA can bring to your agency, for administrators that want access to crunch all the numbers themselves, we have partnered with a company called Xero. This online accounting package integrates with the Healthcare Synergy Web Edition to allow owners, CFOs, and others access to a complete balance sheet and accounting package with no need of manual data entry. This also includes integration with your current banking system for a complete accounting solution. For over 20 years, agencies have trusted Healthcare Synergy for a comprehensive billing solution. However, using the tools is only half the picture. Our billing service takes the mystery out of claim creation, payment reconciliation, and ensures that your claims submitted are fully encompassing all the benefits available to your patients. Our billers ensure that your claims have been reviewed for the appropriate G, Q, value, occurrence, adjustment therapy codes, and much more. Billers monitor your system to ensure that when the proper conditions are met, claims are created and submitted for payment in a timely manner. And also the incoming payments are reconciled correctly, allowing agencies to focus their efforts on other items while cash flow and productivity remain constant. Most agencies with long-term in-house billers often leave money on the table in the form of claims that have been submitted and paid, but are not done so with the full reimbursable amount. As part of our billing service, we include revenue recovery, meaning that our trained billing staff will look at the claims that have already been submitted, and if there was a discrepancy due to issues like the unbilled documented visits, those claims can be fixed and resubmitted. Our third managed service is clinical technology. We have teams of certified clinicians that can assist to ensure the clinical documentation produced by your agency is complete, accurate, and within compliance standards. Certified in ICD coding, they make recommendations as to the use of the proper codes to be included behind based on the complete clinical history of your patient. Answering your OASIS is just one step, but ensuring that the comprehensive questions back and support these answers is often a challenge for your clinicians. By reviewing these documentations with a keen eye, recommendations for compliance and supporting documents are made to your agency. With turnaround time less than 24 hours, this process does not slow down the flow of your documentation. With the new proposed conditions of participation announced by Medicare, or if you're looking to acquire and/or sell your agency, our clinical team can also run a clinical analysis of your agency to show you much, much more than the simple outcomes and reports most agencies rely on today. Specifically, the Home Care Compare website. The data on this website can be up to 6 months old. So knowing where your agency is exceeding or falling short and being able to track that down to a specific caregiver or a specific team or a specific diagnosis allows you to ensure that your agency is running smoothly. Healthcare Synergy is also truly causing waves because these services cannot be ensured to assist your agency without using the proper tools. So by soliciting these services, we will give you our Healthcare Assistant Web Edition for free.
Good morning or afternoon, I guess, for everyone here. My name's Michael Tidd with Healthcare Synergy. We want to go ahead and start the broadcast. We have quite a bit of information to present today. There's several different areas we're going to speak on. So I'd ask you to go ahead and close your office door so you can hear the information. There's going to be some information that you will not want to miss. There's an incredible amount of information that you're going to be hearing maybe for the first time, depending on how where you are of OASIS information and how your case mix are processed. So what I'm looking at presenting is going over the actual OASIS and coding information. This particular webinar is going to have a focus very heavily on the coding side to make sure you're aware of a lot of changes that have occurred with regard to coding that in OASIS C1 as well as in the case mix information and the different Medicare policies that are being thrown out there. We're going to touch on some of the OASIS information as well. That's going to be at the very tail end of the presentation because I want to focus on coding and help you understand, and most significantly with regard to the case mix information that everybody's constantly calling lately since OASIS C1 happened and saying, hey, is my information correct? I have a C1 score, I have 0 points showing. So if that's what you're looking at gaining from this webinar, you will be very satisfied at least having that knowledge. I won't say you're going to be satisfied with the results because sometimes knowledge is a dangerous tool, and in this case it's a little bit very, very disappointing. So let's dive right into the coding side of it. We're going to touch on the OASIS on the very tail end. So with that said, we're going to cover manifestation coding, help you understand what that is, some coding guidelines and coding changes that have occurred. Coding guidelines come out every year. Fortunately, since we're in the process of changing over to ICD-10, there have been no significant changes in the coding, the codes that are available, the description and deleted codes and such. The coding guidelines right now are still the guidelines that were present in 2011. I certainly hope that your agencies are working with coders that understand the coding guidelines and not just somebody that picks up a book and looks in an index and finds your codes, because that can drastically affect how well your agency does and will affect in the as you'll see the information I'm presenting today. So those coding guidelines come out every October. If you've not already obtained the ICD-10 coding guidelines, I'd encourage you to do that. Start looking over those, or at least the person that's responsible for coding at your agency. It gives you the information needed to be able to code. And one of the things that we're seeing with industries is the change in Medicare PPS reimbursement. Everybody has seen their reimbursement go down, so you're not alone. But one of the things they're starting to focus more strongly on is coding practices and using those to reject your claims, cause you to resubmit them after modifications. So we'll be talking and starting right out with that. In August, a change request was sent out to the different MACs, and that was also available to anybody monitoring the news list that CMS provides. This specific change request identified and notified agencies and the MACs themselves that they will start returning to the provider any claims that have a manifestation code as their primary diagnosis. The effective date for this was January 1st, although the edit was implemented January 5th, just a few days ago. One of the important items to know is the effective date is going to be the first date of service for those claims. So not only did OASIS C occur, but also this change request occurred on January 1st. So any of your claims that have a start date, whether it's a start of care or recertification, that have a start date of January 1st will be subject to this particular process. They actually implemented the edit on January 5th, but it does go back to any claims on January 1st or forward. So the contents of this stated that the MACs are going to return the item back to the agency for any RAPs submitted with a principal diagnosis code that is a manifestation code. The error code they're going to identify in your DDE and your other reports is going to be edit code 86. And specifically what they do is they return that claim back to the individual so they can make changes to their coding to prevent the use of a manifestation code as their primary diagnosis code. Now, primary diagnosis codes or manifestation codes are the result or the display of a disease process. The disease process that most people are familiar with is diabetic neuropathy or diabetic nephropathy and other processes that are the display of the disease itself. Manifestation codes are the display of a particular symptom of a disease process. That's always based on the coding guidelines. That's always required. The disease itself always has to be primary and cannot be secondary. So according to the guidelines themselves, certain manifestation codes must be preceded by the coding guideline underlying the etiology. And then we give an example here of diabetes with circulatory issues, and then we have PVD as an indication of or a manifestation of the diabetes itself. When the disease or the etiology precedes that particular item, that's called mandatory sequencing or mandatory multiple coding in the coding realm. Manifestation codes are the reason for M1024, column 3 and 4. Many of you may be aware that when you put a case mix code in column 3 or 4, your reimbursement goes up. At least prior to 2014 it did, but the whole reason for that is you list a V code in 1020 or 1022, and if that's a case mix, that V code replaces a case mix diagnosis code, you would want to put the disease process in column 3, such as diabetes, and column 4 is where you would put that manifestation code at. So that's why there are 2 columns as part of 1024, because a single V code can replace 2 different diagnosis codes in that process. I'll be answering all of your questions, by the way, when we're done, so feel free to type in and answer your questions. We're recording this webinar, so we're not going to interrupt as we're going through the webinar process itself, but I'll be happy to stay on the line as long as anybody else is available to be able to answer questions, or if I fail to get to one, we'll have your question on file and I can reply back to you via email because it's logged in with a GoToWebinar. In case you've never attended a GoToWebinar, let me go ahead and give you a brief area on that little GoToWebinar panel that's typically in the upper right corner of your screen. If you click that little orange arrow, white arrow on the orange background, that'll extend that out. You can type in questions underneath the question section, and those will log for me so that you and those go specifically to me and Gia, our organizer at Synergy, that we'll be able to see that, and then we can answer those questions for you. So if you've never attended a webinar before, that's how you would communicate with us, because I cannot hear you. All of your lines are on mute. So with that said, let's continue on with manifestation codes. The manifestation codes themselves are going to be indicated for you, and I think I skipped over a slide. Nope, I didn't. I'm sorry. The manifestation codes are going to be indicated to you in a few different ways in the coding manual. Slanted brackets are going to be available in the alpha index, so that when you're looking at that alphabetic index and you're looking at the different terms to locate the correct code, you're going to see slanted brackets after your diagnosis code. This is an indication with the blue highlighting the slanted brackets for you. So codes that have a slanted bracket and are in italicized are going to be manifestation codes. The alpha index itself will tell you what code you need to list first because they display the codes in the order you're supposed to use those. You can also look for terms that have in or due to or with to identify a manifestation code. So when we see myopathy in rheumatoid arthritis, that tells us myopathy is a manifestation of your rheumatoid arthritis. Then it will list for you the diagnosis code for rheumatoid arthritis. Then it will follow it by the code that you should use for myopathy. Now, a big important emphasis is you need to be able to look at the tabular index, where it actually look up this code in the alphabetic index, but then also verify that code to see whether a manifestation code is needed for that disease also. And I'll be showing you some examples of that as we go through this process. Conditions in italics in the tabular list with instructions to code first the underlying disease will tell you that this is a manifestation. The term code first underlying disease is an indication to you that you have to code something before this particular code. So when we look up background diabetic retinopathy, you're going to see this is the code to identify background diabetic retinopathy, 362.01, but you're going to be coding diabetic with optical indications as 250.5 and another character first, because diabetes is your primary diagnosis code, or at least precedes the manifestation code. Most have an in-disease classifiable elsewhere also. So you'll see code first underlying disease, or you'll see in-disease classifiable elsewhere in the code title itself. So if you're looking up in that alphabetic index and you see acute myocarditis in disease classified elsewhere, that's also another indication that this is a manifestation code, so that all of these are indications to you. Not all codes or conditions that may be manifestations are in italics. So there are conditions that there are some assumptions, and that's what is spelled out in those coding guidelines, that it's so important to read and understand. Because the coding guidelines will let you know that when you have diabetes and you have gangrene, that's an assumed relationship, and gangrene then becomes a manifestation of diabetes. If it's listed strictly as this in the alphabetic index, not every patient that has gangrene, obviously not everyone has diabetes. So it's not required to code diabetes first in that kind of a case. But where a patient has diabetes and they have gangrene, both, then it's an assumed relationship unless it's specified by the doctor that this gangrene is not caused by diabetes. So there are some cases. Another example would be where they have an ulcer. It could be a stasis ulcer, not a diabetic ulcer. So there will be cases to where 707.1 codes may be a diabetic ulcer or may not be a diabetic ulcer and just a stasis ulcer. So the documentation, the clinical documentation, will have a fact for that. So you'll be able to look at that. Going on to the next page here, 3 or 4 important items. The etiology code is first. That's a cardinal rule, always has to be, cannot be violated. The etiology is the first code first value. It must immediately be followed by the manifestation code. So in that kind of a situation, you will never have a manifestation first, and you will never have a gap between the manifestation and the primary, or I'm sorry, the etiology or the disease process. The manifestation may never be the primary diagnosis. This is a direct rule, or the opposite of this rule. The etiology, therefore, has to be first, so you can never have a manifestation as your primary. Now, a lot of you may be saying, well, we're seeing the patient for the neuropathy. They just happen to have diabetes. So I'm seeking care for the neuropathy, and therefore your gut feeling and some of your agency at your staff may be saying you have to code neuropathy first because that's your focus of care. That is typically the definition of primary code. You also have to follow the coding guidelines, though. So your clinical documentation would be indication in your narrative that you type. I know everybody hates to write that. They just want to check boxes. But you have to specify in the documentation by writing neuropathy is the cause, neuropathy interventions, and so on. The patient may have had diabetes for 30 years and be fully aware of how to self-inject insulin and how to properly do their diet and all of that stuff. You may actually be there just for neuropathy. But because of this cardinal rule written in red, it can never be primary no matter how much you want to fight the system. This is why the change request has been published by CMS. It's a way for CMS to keep money longer because you're not following the proper rules. So the etiology and the manifestation always must be together. You cannot code diabetes as higher up in your list as row 1 or 2 of your diagnosis case mix codes in 1020 or 1022, and then also list hypertension and chronic kidney disease and other problems, and then follow that by neuropathy. They always have to be immediately one above the other. When such there are times when you'll have combination codes, but when such combinations exist, such as a manifestation and an etiology, you're going to be told use an additional code at the etiology level. They're never going to leave you totally blind. They're going to give you hints inside the code book, and you'll see a code first, underlying disease, at the manifestation code. So code first does not mean that it has to be the primary code. So sometimes when you're listening to that, you're going to hear code first, diabetes, for example, for the one we've been using, and then you're going to code neuropathy. That does not mean that neuropathy has to be, or diabetes has to be your primary. So I've broken that down to help understand here in the next slide or two. Here are very common manifestation coding scenarios that a lot of people disregard. Hypertension with chronic kidney disease is a manifestation etiology relationship where you would code the hypertension and you'd follow that with chronic kidney disease. A patient that has hypertensive heart disease or hypertension, you're going to have to look at the documentation itself to decide whether this applies to your patient, but these are cases where you would code hypertension as your etiology, and then you would code heart disease, heart failure as a second code as your manifestation, because the two would be related based on what the doctor provides in their documentation. Diabetes has several different manifestations, so you would code diabetes, and then you would code one or more of the different manifestations of that particular disease. Diabetes is one of the few diseases where you actually must code diabetes multiple times depending on the manifestation they have. So I don't really go in depth on that in this webinar, but there is a different code for diabetes with neurological, diabetes with renal, and diabetes with ophthalmic manifestations. So in this kind of, if the patient had all three of these issues, you would actually have 6 codes that you would have to use. You would use diabetes 250 point, neurological is 6, I believe, for neuropathy and such. Renal is 250.40, and ophthalmic is 250.50. So in this kind of a situation where you're going to be coding, I'm sorry, I went back. Let me go back to this other slide. I clicked on it trying to highlight. So you'd have to code diabetes with the 250.60, and then you'd follow it with your neuropathy or your neurological manifestation. You would code 250.40 and then follow that with your renal manifestation, and then, which commonly is chronic kidney disease, and then you'd list 250.50 and then list your ophthalmic, which would be background retinopathy or something of that nature. An important note for you to know is that you do not have to code all 6 of those together. You can commonly code the one focus of care, such as neuropathy or renal disease, first or higher up in your codes, and then you can follow these others that the patient may have that's going to impact the care farther down in your code sequence. So as most of you know, your 45 can have many more diagnosis codes than your OASIS can. So it's important to understand that as you go through, you can code diabetes with neuropathy in the top 6 diagnosis codes and put diabetes with renal, diabetes with ophthalmic later on the 45 and never have it appear on those 6 diagnosis codes. Unless all 6 of those, you have to make sure you order based on the treatment or the focus of care of the patient. So sepsis is another case that you have manifestation codes that are probably present. Urosepsis is one of the only cases off the top of my head that I know you don't have. A patient that has urosepsis, that's a combination code. It's the 599.0 code by itself. Says they have a urinary tract infection and sepsis. Altogether, just one code. But if they had another issue of sepsis that was a blood disease or chronic organ sepsis, then you would list that as 2 or 3 different codes. Again, you'd have to look at the coding manual. So the next slide I want to show, because these are just common areas that you may have, the next slide I want to show is 2 different pages of the actual coding book. This is taken from the coding online tool that we use, made by Decision Health. I think that their books are one of the best. By no means is that an indication you have to buy them, but they give lots of clues inside the book that are very, very helpful. So this is a case where we have hypertension with chronic kidney disease. This is a manifestation coding situation. So we would list the hypertension code 403.91 or 90, depending on the level of chronic kidney disease. And then down here, it's telling us, and I've highlighted this in yellow. It won't appear yellow in your book, but I've highlighted it. It says use additional code to identify this stage of chronic kidney disease. So when you go beyond the alphabetic index and actually go to the tabular index, which has the diagnosis codes listed, they're going to give you a lot of detail here. This $sign, many books are going to have a different indication. The $sign happens to show that this is a case mix diagnosis code. You're going to get points and more than likely a higher reimbursement for using this particular diagnosis code. Down here in 585 I'm used to clicking on stuff as I'm doing presentations or individual trainings. 585.6 would be our end-stage renal disease. This would be one of the possible codes that could be used for 403.91. Notice that in the Decision Health book, it kind of guides us because it tells us the ranges that are typically used with this particular diagnosis code of 403.91. When you use a 1 as your 5th digit, then it says use an additional code to identify the stage, 585.5 or 585.6 as 2 different options. The 0 indicates that it's not in stage, not type 5, and it gives you a different range of those. But down here on 585.6, there's another indication that this is a manifestation code. It's going to tell us in the coding book, code first hypertensive chronic kidney disease if applicable. So just because a patient has chronic kidney disease, don't mistake me and say, well, Michael said I have to code 403. You don't. That's why it says if applicable. If the patient has chronic kidney disease and does not have hypertension, you would code just this code. Or if they had diabetes and they had hypertension in stage, then you could code that as well. So it comes down here, and I've highlighted yellow again. This is where you would see that, hey, this is a manifestation code. I must code first or before this code a different code. And then again, it gives me the ranges of the codes that I could use if it really is hypertensive chronic kidney disease. And then there's some other codes that this could also be used with. Kidney transplant, that was a failure, diabetes, and so on. I didn't really show all of those, but this is an example of that. So the next page is focusing on diabetes, and this one I actually showed the alpha index as well as the diabetes and the neuropathy code. So in here is an example of the online coding center that we use. There, how it looks in the book is very similar probably in your actual hard copy coding book, but I'm going to look up the terms diabetic neuropathy. It's going to give me hints, and like I said, when it's in italicized and it's in brackets, it's telling me that this is a etiology, which is a disease, followed by a manifestation code. So I can look in here and know that I'm going to be using 2 codes. When I go to the tabular book, it's telling me 250.6 is my diabetes code. In Decision Health, and I'm sure that you have something similar in your coding manual, it shows me a plus saying when I use 250.6 diagnosis code, I must have an additional code. I cannot use 250.6 by itself. If you do, you're using have a manifestation coding problem. So I have to use another code. That's what this plus tells me. When I read the text below it, it'll say use additional code to identify manifestations. And it gives me a wide list of those potential manifestations. Any one of these codes would require a 250.6 code present. In this case, we're looking at 357.2. I've pulled that section of the code up, and again, at this level, it tells me 2 things. One, that this is a specific manifestation code, not an optional one like the chronic kidney disease was. Decision Health shows an M that tells me this is a manifestation code. Down here in the notes, it says code first underlying disease. So that helps me if I'm using the coding book and I've got some training that it tells me when I'm looking in the alphabetic index, I'm going to need 2 codes. When I'm looking at the diabetes code, it's going to tell me I have to use an additional, which means after this code. When I look at neuropathy, if I try to use this as my first, I see here that this is a manifestation code. I also see here that says code first underlying disease. So therefore, when we're going through this process, we cannot code neuropathy as our primary diagnosis. We cannot code it before diabetes, even if neuropathy is our focus of care. So on the next couple of slides, I've given some sample coding screenshots to help make sure you fully understand this, because I don't want to see your claims get rejected and for you to make corrections, because obviously that has implications on your payment and your cash flow. So this very top one shows neuropathy and diabetes. I highlighted a red so you can immediately see what I'm trying to show you. This, if we're just saying we're in there to treat neuropathy that's resulting from diabetes, this might be how somebody codes it. In 1020 is our primary diagnosis code. That's the reason we're there. But the coding guidelines say we cannot code that as primary. So if another coder came in and said, well, this is neuropathy due to diabetes, I remember Michael said they had to be together. This also would be wrong or incorrect coding. While you're there for the neuropathy, the coding guidelines say diabetes has to be first. It can't be after the manifestation. So both of those would be wrong. In this case, we've coded diabetes as our primary. We've coded 250.00. This particular code says that the patient has diabetes, but they don't have any manifestation. Below that, we've listed that the patient has the neuropathy and diabetes. In case you're not clear, by the way, there are different codes for neuropathy. You could code a situation like this, where the patient has diabetes, but they have no manifestations. If that's the case, this would be an okay code to use, and the only code you could use, but you would not be able to use 357.2. You would need to use a different diagnosis code for idiopathic neuropathy. So that could be a valid situation where these two are not related, but these would not be the correct codes to use in that process. Down here in 1020, this would be how you would correctly code it. Diabetes with neuropathy 250.60 and neuropathy and diabetes 357.2. So to make sure you're comfortable with the fact these don't have to be your primary, I did one final one to kind of show you. And even though I highlighted them in red because the order's backwards, they don't have to be primary. Here I've specified we're doing aftercare of a fracture. The patient has a fracture of the femur. We're putting our correct V code for aftercare of fracture present. This is a case where we're actually using 1024, but we've put in our neuropathy first and then our diabetes. While these don't have to be the row A or B, they do have to have diabetes first, followed by neuropathy. So there's several questions here about presentations. I want to go ahead and let you know we will have these slides available for you. After the presentation, we'll be emailing those to the email that you registered with. So you'll be able to get those. If you're watching this recording on demand, then if you email, then we can send those to you as well. I don't know if the link that has this recording is also going to have the handouts on that same web page, or whether you'll have to contact us for that. But you will have the presentations as well as another handout that I'll be giving to you once we get down to the use of insulin. So the next thing, well, actually we're almost at insulin. The next area that we wanted to cover was the use of daily insulin. Many of you have patients that require you to go out and visit the patient to administer insulin. As you're aware, home health is supposed to be an intermittent service which is defined in the conditions of participation as 21 or less skilled nursing visits. If you're going out once a day for a 60-day episode, or maybe even multiple times in a day to administer injections of insulin, you're going to exceed that requirement. And Medicare is going to give you a difficult time for that because your documentation must say patient can't administer on every single visit and why they can't self-administer. Otherwise, you're at risk of having those visit notes denied. But the final rule made some changes and suggestions on the use of daily insulin. So the first thing I want to cover, the first slide or two, is covering the good and the bad of the final rule. Some of these are just bullet points that we're not going to cover in this webinar. There are some bullet points that we'll expand on later on as we go through. And then I'll cover one of the bullet items, which is insulin needing home care to be able to support that. So there are some diagnosis codes that they suggest. So these are specific bullets that I thought pertinent for you to be aware of as we go through the final rule. It was published November 6th of 2014. It's just now reaching just over 60 days that it's actually been effective. There's going to be a change in your CBSA codes. The CBSA is your metropolitan area that you're getting paid on for your patients. A CBSA code was originally brought out in 2009-2010 timeframe, not specifically certain of the year, but the patients before that used to be an MSA code, if you remember that. They changed to CBSA codes. They're now updating those CBSA codes, and the boundaries for those areas are changing. The 2015 final rule stated that they're going to take a 50% blend of the old information and a 50% of the new information. So the CBSA boundaries are changing, and each boundary has a different monetary reimbursement they're giving you for those CBS areas. So what they're doing in this calendar year, or fiscal year, 2015, is they are giving you a 50% blend of the old boundary area and a 50% blend of the new boundary area in 2015, October 1st, 2015, when they come out with, January, when they come out with the new federal rule. Then you'll actually be, as stated, you'll be receiving 100% of the new boundary areas. So you probably want to invest some time to find out what your CBSA service areas you serve are, be able to drill down to the different payment rates to see what your reimbursement is for those areas, to see how that's going to impact you next year. This year it's a 50% blend of both to lessen the impact if you're going from a high metropolitan area to a low, and so on, and save money for Medicare, I'm sure, if they're going from a low to a high. They've also made information about the therapy assessment. Hopefully you've received some information. We're not going in depth on this particular topic in this webinar, but the therapy assessment has changed for any episodes starting January 1st or going forward. Your therapy now is done every 30 days. An evaluation is done every 30 days per discipline. So if you have PT and OT on the case, each would have to do their own evaluation, and it would have to apply to them, and their 30-day clock would reset the day they do that evaluation. Hopefully this far into the 2015 year, if you had an episode that started December 31st, it started before January 31st, and you still must do every 13 and 19 therapy visits if you're exceeding that, along with your 30-day assessment. This is only affecting episodes that started January 1st or later. It does not look at when therapy started. It looks at when the episode started. So in a case that you have a patient starting recert or start of care on December 31st, and you didn't immediately bring therapy on, they came in January 15th, you could not say, well, we only need to do it every 30 days because the episode started December 31st prior to this effective rule. Even though the therapy didn't start until after, they're still bound by the old rules until that one episode is done. Any subsequent episodes that start on or after January 1st default to the full 30-day rule that's in the final rule. Face-to-face, we're also not going to cover. In a face-to-face scenario, they've eliminated the narrative. I believe, in my opinion, that they've convoluted and made it even more difficult to work with, though. In case you haven't read the final rule, I encourage you to read it. Make sure you get information from your state association, because the final rule, face-to-face, they've eliminated the narrative requirement from the face-to-face form, and indeed now you don't even have to use a face-to-face form. Based on the guidance from CMS, you could write that information on the 45, The catch-ya and the gotcha that's going to cause lots of problems for agencies, in my opinion, is that the physician's office must, not optional, must have a narrative documentation in their records indicating the face-to-face encounter occurred, indicating that the patient's homebound, that they need services, and so on. So they've not eliminated the narrative, they've just made the physician keep it in their records instead of giving you a face-to-face form that you would file in yours. So if you haven't already read that, I would strongly encourage you to do so, and also pay attention and make sure that you're getting the that physician's documentation that they have in their records put into your records. Because if you ever get an ADR for a claim, you ever get a survey question from the ZRACs or the ZPICs, they will deny your claim if the physician does not have that information in their records. And if that's a situation where you've already provided care, believing that the physician said, yes, it's in our records, and they cannot locate that information in their records, your claim will be denied, or they'll take that money back. So they've, in some people's opinion, they've eased it. In my opinion, they've made it much harder and much easier for agents, much harder for agencies, much easier for Medicare and auditors to come back and deny it well after the fact. They've implemented pay for reporting, another area we're not going to cover in depth in this particular area. Pay for reporting is covering your OASIS submissions. In the past, CMS has said, hey, there's a 2% penalty if you don't submit your OASIS within a 30-day time period. Now they're carrying that farther forward. If an agency doesn't submit a certain number, and I believe it's 60% or more this calendar year, but I'd have to double check that, and it's in the proposed rule, it might be 70%. But specifically, if the following subsequent time period assessment is not submitted to CMS, that's what they're looking for, you will receive an additional 2% penalty on top of not submitting your OASIS on time. So for an agency that's submitting all of their OASIS on time and they're collecting all of the OASIS as they should, this won't be a factor to them. But if you submit a start of care and you fail to submit a discharge, or you fail to submit a recertification and so on, this is the agency that's going to be caught by this particular new process. They're starting at a low percentage. They're working themselves up. By 2018 or 2019, I can't remember, but it is specified in the final rule, they will be looking at a 90%. So the agencies that have to be really concerned here that come to the top of my mind are agencies that typically do what I call a paper discharge. They say it's too difficult to go see the patient won't let us come, we're just discharging the patient, we're not capturing OASIS for them. Those are the agencies that are going to be caught by this particular assessment process because they want to see the start of care and the recert. They want to see a recert and a recert. They want to see a recert and a discharge if you're following through that process. Or if you're admitting the patient for a single episode, they want to see the start of care and they want to see a discharge because that's how they compute that the patient's getting better. So they're paying for reporting, they're paying you that extra 2% that they're not going to take away if you're submitting all that information on time. They give an actual formula to figure out what your percentage is in that final rule, so I'd strongly encourage you to read that final rule. Even though it's kind of boring, it'll take you, depending how quickly you can read and digest, it could take you 2 or 3 hours, it could take you an entire day or an entire weekend. But definitely read through that and know. They have expanded the rural add-on for 1 additional year. If you are a rural agency, you get that 3% add-on. The final rule does indicate this will be the last year unless Congress takes action to extend that again. So if you are a rural agency, know that you're going to get that 3% this year, but next year, unless Congress acts, you will no longer get that 3% add-on. So you'll, in effect, get a 3% penalty just because you don't live in a metropolitan area. They've also discussed, and I'm sorry about the misspelling there, it should be value, not vol, but I thought I went through these well, and I did not. Value-based purchasing. is going to be a new incentive that they're doing. We're not covering that in this particular webinar, but effectively what they're doing is different than CMS has done in the past, where they have implemented voluntary trial processes for changes they're looking at doing. This particular process, and you'll definitely want to read it, unfortunately they have not identified which states will be affected, but what they're doing is an entire state will go under value purchasing. They've indicated they're going to start with 2 states. They give suggested states in the final rule, 8 or 10 of them I believe, but they are going to select this calendar year which 2 states will start value purchasing next year. And that entire state, every home health agency will be paid under that new process. And effectively it's based on quality care provided by the agencies. So they're looking much closer at your home health compare numbers, and that's one of the reasons I believe they're doing the pay for reporting. They need to see the start of care and your discharge to see that your numbers have increased and improved. ICD-10 going to be effective October 1st, 2015. You have a few months left before that becomes effective. And then insulin injection standards is what we're going to cover next. And then case mix adjustments we'll also be covering in this webinar. So insulin injections, I'm sorry, before I move there, the PDF and the text version of that final rule is included in the handouts. You don't have to write this down. You can visit there and get the PDF version or the text version. The PDF version is going to be tinier print. It's much smaller pages because of that. The text version, I believe, is easier to read, especially if you're on a computer or something, and not on paper. But you're welcome to download either one of them. They are the same document. So I would definitely encourage you to obtain it and read it if you have not already. Maybe reread it if you missed some of the information we're presenting today. Insulin injections is something that is laid out for future probability. Probability is my word there. In the proposed rule and the final rule, they've indicated diagnosis codes will be covering, and that's one of the handouts I'll be giving you, but it is in the final rule, that they're going to consider next year or possibly in a future year, they've not specified when, that they will start looking for specific diagnosis codes on your OASIS and on your claim to justify that the patient's not able to self-inject insulin. So there is no projected rule. They've discussed it in the final rule. Table 34 if you're looking at that table, but I'll be sending you an extraction that I did that you can look at. They've broken them down into these specific areas that need to have a diagnosis code present, and it's selected diagnosis codes from these areas. So amputation, obviously if the patient has certain amputations like a thumb or a finger, then it would justify their inability to self-inject insulin. If they have vision issues, they can't see to draw up that insulin well. If they have cognitive or behavioral issues, arthritis, movement disorders, after effect of a stroke, another central nervous system disorder, or intellectual disability, those are the groups that they're looking for to be present on your patients. Those are going to be diagnosis codes that appear on your claim. So while your nurses may do a great job of documenting those on your paperwork, on your 45, on your OASIS, on your clinical notes, if it's not listed a diagnosis code, then you'll be a possible candidate in the future when they implement this policy, because it's not in effect today. There's no effective date for it. But you'll be a candidate for grabbing that money back for that episode you've already been paid for. This is a snapshot of the document I'll be sending to you just so you can see a few of the codes in these different areas. Amputation, amputation of thumb, wrist status, and so on. Amputation of a leg is not on the list, so you couldn't document that, or a foot and so on, because obviously you don't inject with those. Movement disorders, when a patient has Parkinson's, or when they have other diseases that are listed, when they have effective from a stroke, they have hemiplegia of the dominant or the non-dominant side, those would justify. When they have cognitive issues, dementia, and so on. All of those are samples of codes. There are lots more. I think it's 6 or 7 pages of codes that are listed. But the important thing to know is they're not currently doing it now, so you're not going to have any possibility of taking back money. But what you should do is start looking for those codes when you have a patient that you feel cannot inject. Just because the patient refuses to learn or doesn't want to and the caregiver is not available won't suffice when they start enacting this policy. And that's what a lot of agencies are currently doing. So look at the list I'll be providing along with the handouts for you to be able to understand. Now I want to go talk about coding and case mix changes. The coding manuals, I strongly encourage you to get a coding manual and the guidelines and the new codes because they're talked about in that process. And then we'll be covering the case mix changes. So here is where you can find the coding guidelines if you don't already have a copy of those. Most of your coding manuals will have the current coding guidelines inside of the book. In Decision Health, it's in the first 50 pages or so. In some of the other books, I'm sure they're there. I think Ingenix puts them in the very back. I haven't used the PMIC book, but there are documents at the very bottom there here, purchase a new one every year. And I'll tell you why in the very next slide. The code changes are going to be listed at this website, so you can look at and see what the changes to the codes are. Code changes will be a new code, a deleted code that's no longer available for use, or it will be a description change where they've changed the wording of the diagnosis code. So you want to review those periodically. Your code book will have those changes present, and most code vendors will tell you what has changed in the first 100 pages or so. So you can kind of be aware of those. You don't necessarily have to go out and get those, but this is where the resource is because I like to educate people on how to be self-sufficient where possible. The reason you want to buy a coding book each and every year is this screen here. This is part of the reason, we'll expand on it, why your case mixes are so low. All of the diagnosis codes on this page no longer give you case mix points. If you look at the very bottom section, your pulmonary highlighted in pink, you have chronic bronchitis, you have chronic asthma, and you have emphysema listed there, some diseases that you treat on a regular basis. They have blindness, which used to give points. It no longer does. You have psych disorders of dementia, Alzheimer's disease, and others that no longer give you case mix points. So a lot of you have correctly learned to code those so you get payment points for those. But if you don't have a current diagnosis coding book, you're expecting those to still be case mix diagnosis codes, and they are no longer. At the very top are your psych items. So looking at the last code in the far right column, you have depression listed. Looking here on the second from the bottom in the Psych 2, you have Alzheimer's listed. You have 294.20. You have 294.10. So several diagnosis codes. I think 294.11 is incorrect. I believe that still is a case mix code, but I'm not 100% positive. You have all of your bronchitis down here, your COPD and such. Those, unfortunately, are no longer case mix diagnosis codes, and that's a significant reason why many of you are receiving a lower case mix than what you have last year, and your coding practices haven't changed, so you wouldn't expect that. But there are 200 codes between Psych 1, Psych 2, blindness, vision, that are no longer case mix codes as of January 1st. So that's why you want to make sure you have a coding book, even though there were no code changes. There were no code changes this past year. No new codes, no deleted codes, no description changes. There was a change in those case mix codes, and if you're using a 2013 or a 2012 book, or even a 2014 book, your book is going to say that's a case mix code, when in fact they are not in 2015. So let's go into the training of what I suggest for ICD-10. This is going to be fairly brief, but I suggest you start training now, that you start practicing. I'm going to talk about go live and why and implementation. So begin training your staff now. Look at the coding guidelines. Get a copy of those. Those are available on a similar website that I put previously in the presentation. Make sure your staff understand anatomy. Many agencies are purchasing an anatomy refresher book because ICD-10 goes to greater length in understanding the anatomy and where certain items are located at. Train your intake staff and to be able to ask the questions needed to get additional documentation to clarify the item information needed for ICD-10. ICD-10 covers multiple combination codes, so they're going to have a lot of codes that you only need one code for, which is really great because it leaves you additional codes to use. In your case mix, 6 diagnosis codes in OASIS, but you have to have the information for that. Train your referral sources on the information that you need. I would probably focus on the clinical staff at the doctor's office as opposed to the physician, because they're the ones who are going to have to dig through and get that documentation for you. Let them know at the very least that you're going to be asking for more documentation that they're probably giving you. The doctor themselves may have to change the level that they're going to have to document. But since doctors' offices are going to fall under the requirement for ICD-10 also, that case is probably going to be handled, but it may not be initially. So train those individuals to start getting that information. Train your assessing clinicians to do a better job when they're doing OASIS. They cannot simply check boxes and say the patient has a pressure ulcer at stage 2. You have to state where that's at. Show in the body diagram, because one of the big advantages of ICD-10 is it's bilateral, meaning that you can specify a left ankle or right ankle, left buttock, right buttock. Currently in ICD-9, we can simply say that the patient has a pressure ulcer stage 1 or 2 or 3 or 4 on the buttock or the hip. We can't say that they have 2 with diagnosis codes. We can't say they have 1 on the left hip and 1 on the right hip, and therefore it's making it difficult for this patient to heal, because when we turn them on 2 of the 4 sides, they're further breaking down that particular pressure area. But in ICD-10, with the diagnosis codes, we can do exactly that. We'll have to do exactly that, because we'll specify the code itself will say the type of issue, such as a pressure ulcer, the location of the issue, that it's left and right, and the one code, which is wonderful, will say what stage that pressure ulcer is. But your clinicians are going to have to do a much better job of assessing what they're seeing in addition to the documentation you're getting from your referral sources, your intake staff. Review your current process. Who touches diagnosis codes in your office? They're all going to have to be aware at some level of what ICD-10 is, because the codes they're used to 250.60, will not be 250.60 in ICD-10. So I'm not going to get into the ICD-10 education itself. What I'm going to suggest here is that you start practicing now. January through April, it's strongly suggested to do 1 to 5 cases per month coding in ICD-10. In May to June, I strongly suggest to do 1 to 5 cases per week. Or if you have less than that, you're a small agency, code every single assessment on ICD-10 to get the practice. In July, I would say 1 to 10 cases per week to increase that. And then in August, I suggest agencies code every case in ICD-9 and ICD-10. The reason for this is dual coding. A lot of agencies will say, why, Michael, why are you telling me that I need to have such a drastic implementation and training plan? Why do I need to start coding in August every single case when it doesn't go into effect until October 1st? It's a very valid question. The reason being is that your claims, when the RAP is submitted as late as September 30th, you're going to be submitting ICD-9. When the final claim is submitted, you're going to be submitting that in ICD-10. Now, the Synergy software will do that for you automatically, assuming you've entered your ICD-10 codes. So an agency could choose to say, you know, you're claiming the sky is falling. Why do I want to do that? I'm just going to keep doing ICD-9, because how do I know the patient's going to be on service at the full 60 days of the episode? I could be sending my claim in September 15th or September 20th or 30th. I won't need ICD-10 for that. That is valid. But if you wait to code that in ICD-10 until you really need it, then your agency is going to have to review the case twice to really figure out what those codes are. There's further information needed than simply that there's a pressure ulcer on the right buttock and it's a stage 2. There's further information needed to be able to document fractures in the location, the area of the bone, and so on. You may not have that information in your records. You may have to then go back to the physician and say, we need clarification of this. We were able to code ICD-9 fine with what you gave us. Now we're trying to build a final claim, and we have to do it in ICD-10. And we need to wait for the doctor's office to send us the information. You're all aware of how long that can take. So that in itself can delay your billing because you're wasting effort looking at the case again when you already have a high workload just of maintaining your current claims that you're processing. Now you're delaying your billing because your episodes have to be recoded on ICD-10 and you're waiting on clarification from the doctor. And then you're going to have loss of proficiency because your clinicians, your staff are not coding in ICD-10. It's going to be brand new to them. So that's why I suggest you start coding now so that you're aware and have practice in some level of proficiency. I don't have the statistics for it, but in the multiple trainings I've had in ICD-10, the Decision Health has done a really good job of stating and giving an example of how long it has taken for the Canada to switch over to ICD-10. They lost close to a 30% productivity because of ICD-10. They had to look up the codes. They didn't know what they were. They were looking at other documentation they were missing and so on. So it's a significant potential of losing income. So in addition to just starting code now, outside of this, I would suggest, and I would pass on the information that I've received, that agencies look at getting a line of credit because Medicare may not be ready for the volume of claims. They may not be ready for ICD-10. Your agency may not be ready for it. They may get rejections on claims and so on. So it's strongly suggested to have a line of credit. Start practicing now. Anybody that's interested, Sharon Molinari, who I learned coding from, I have a very high level of respect for, is doing coding seminars in Las Vegas, very economical, in April and July for agencies to start getting training. There are resources, webinars, and on-streaming media that you can purchase through MedPass and Decision Health and other locations, other resources, local seminars I'm sure your state associations are having as well, but make sure you get ICD-10 training if you haven't already. So I've got a little drum roll going on. This is where you're really going to need to start paying attention if you haven't already. I apologize for some of the people on the East Coast that may have to leave. We probably still have another 30 minutes into the webinar. If you wanted to stay, you're welcome to. Otherwise, I guess you could watch the replay. Here we're going to be talking about how your case mixes are calculated and help you further understand why they're so low. Not just the loss of those diagnosis codes, but other reasons as well. So we're going to be talking about case mix rebasing. We're going to talk about case mix point changes. We're going to talk about changes in the HHRG threshold, which is what your case mix value corresponds to. That's the C1, F1, S1, or whatever it might be. And we're going to talk about loss of diagnosis codes. So this is the drum roll. Hold on your seats and wake up. Get a fresh cup of coffee. So an ongoing and projected, with no projected end, is case mix rebasing. In 2014 PPS rule last year, you may remember that you had a loss of case mix values because CMS came back and rebased the case mix weight from what was then a 1.3 to a 1.0 as an average case mix. That cost several agencies as much as 26% of their revenue in its loss because of the case mix rebasing change, also in addition to the diagnosis codes that were no longer case mix codes. In 2015 final rule, they again rebased that case mix, and they proposed to rebase it every future year. So the CMS is looking at the case mix, and when it gets higher than what they think it should be, they are effectively changing the rules to make sure that you don't get a higher compensation than what they think you should get. They're adjusting it because they say case mix creep. It continues to go up because agencies are learning how to game the system, they're learning the rules, and therefore the CMS feels they have to reset stuff to stay within their budgetary constraints, and they're taking away case mix diagnosis codes, they're lowering the case mix weight of your different areas to be able to accomplish that. So I won't be going into the specific case mix weights themselves, but what I will be covering will be how to understand the case mix calculation. Given this, there are 4 equations, technically 5, but CMS says there's 4, in the OASIS that were introduced with OASIS-C. There were 4 equation models introduced back in 2010. Agencies may or may not understand this. There's still a lot that don't. It's broken down into 2 specific questions that determine which model you're in. An early or a late episode as decided based on M0110 or 110, and a low or high therapy based on M2200, your therapy need question. So in this process, these 2 questions are what determine whether or not you're in grouping equation 1, 2, 3, or the 5th hidden one, number 5. Equation 1 is determined by an early episode and a low therapy threshold. Equation 2 is an early episode with a high therapy threshold. Or equation 3 is a later episode, which is your recertification of 3rd or subsequent assessment with a low therapy threshold. Or equation 4 is a late episode, again, 3rd or subsequent assessment with a high threshold or therapy. And if your patient, your ranges, by the way, are a low therapy is 0 therapy to 13 therapy visits projected in M2200, and a high therapy is 14 to 19 therapy visits projected in M2200. If your agency decides that that patient needs 20 or more therapy visits, then you're in this hidden equation number 5 that disregards what M110 is. And they automatically say, we're going to give you specific points based on that, following some of the different rules here. So when an agency goes in and says, hey, we only think the patient needs an eval, but we know this patient needs therapy because they've just had a knee replacement, they've had a hip replacement, muscle weakness, or whatever the case may be, the agency's doing the clinicians, are doing a disservice to the agency, because the clinicians are really supposed to be taking a best guess or coming up with a number after talking to the therapist of what that's needed. A lot of our clinicians lie or take the cheating way out, and they say, we need 1 therapy visit. We need a PT to go out and evaluate the patient, and then he'll decide how many therapy visits are going to be needed. But at the start of care, I only know they need 1. And what they're doing is they're denying you potential money up front by doing so. By no means do I want you to lie and say every patient needs 7 or 8 or 10, but really they ought to be looking at that, and the nurse should be coming up with, based on experience and discussing with your therapist, what can be used to give a good estimate of what that patient really needs. But there are 5 different models that determine what the reimbursement is going to be to the agency. Points are awarded based on 3 areas besides those grouping categories. Question answers to specific OASIS questions, diagnosis coding groups, which can give you the points that we're going to show you, or the equation model determined by M2200 and M0110 or M10. There's a fabulous document that I strongly suggest you get, really bottlenecks or narrows down and presents it in a very comprehensive way. Go out to this website, fill in your name and your email address, and you'll get the document that's the source of some of the other information that I'm presenting. But I want to compliment SHP and give them kudos for giving some fantastic material to help understand exactly why the case mix points are so low. So at this point, I'm going to cause you to get some medication for headaches. Be aware that you may get nauseous, and you're going to get in a bad mood if you don't already understand this information, because the rest of this webinar is not pretty. We're going to dive down into, these are the case mix diagnosis code groups. These are all of the 2014 groups in black as well as red. In the red, these are the diagnosis coding groups that were removed in 2015. So we have blindness and low vision and the specific diagnosis code ranges. Psych 1, affective and other psychosis, depression, and the specific ranges. Psych 2, degenerative and other organic psychiatric disorders, and the ranges for those, and pulmonary disorders. So they've taken away 4 major ranges of diagnosis codes that used to get case mix points that no longer do. Of those groups, these are the common diagnosis codes that I use when I'm doing coding for patients and are present in yours as well. I've had some clients that called that wanted to know why they got a C0 even though they were using CHF or COPD, depression, dementia, and so on. These codes on the left are the codes that are very regularly used by agencies because they affect a lot of your patients. The ones on the right are also common codes that would be lost based on what an agency may treat. I'm not entirely sure why CMS removed those. Please don't shoot the messenger. This is all in the federal rule. But, typically you're going to be treating patients with CHF or COPD. They just get out of the hospital. You're doing visits. They may have the disease process and on a start of care, and it seems stable. You're coding it. They come back from a resumption of care, and now you're doing extra visits for those particular disease processes. The SCICs are no longer a payable option, although you do still need to do SCICs. Most agencies don't, but SCICs are still a valuable assessment tool to indicate how significant your patient is. You just don't get paid for those changes anymore. Why CMS removed these items, I cannot say. I know it's a very big disappointment, though, and a major reason why you're now getting C0 points instead of a C3. Here is a list of the clinical-related questions that were available in 2014. With 2 exceptions, they are still present in 2015. Agencies are no longer getting answer results for M1200. They removed the case mix questions for blindness and low vision, so it seems logical they would remove case mix points for a patient with low or partial or a significant vision issues. You're no longer getting case mix points for M1200. You're also not getting case mix points for M2300. 2300, in case you don't know the numbers, is the injectable question for medications. So you used to get points if a clinician answered injectable meds as, I believe it was 2 or higher. You no longer get points for that question regardless of how it's answered. So they've taken away 2 very big points that used to give you case mix question points as well. This is the area that's going to make you sick to your stomach. This is the tool that you're going to get from SHP along with another 4 or 5 spreadsheets in the workbook. I would strongly encourage you to go out and grab that. This effectively is the list of the clinical questions. This in the next 3, if not 4 slides, are going to cover each and every row where it's possible to get case mix points. This column is your 2014 values. And then in here is on the far right is your 2015 values. There are color codes that SHP has put on here. Green indicate a light green is a point increase to where, for example, here if we go to row 12, we have 8 points when it was a category 2. Now in 2015 for column 2 on row 12 we have 11 points, which is good. We increased there. Dark green are areas where the points were added. So we did not, if you go back to column 2, instead look at row 9, we received no points to where now we're receiving 6 points. So that's also good. But look at the amount of that pink or that red color. A light pink is where we've decreased our points, and a dark red is where we've totally deleted points. So we can see row 13 all across the board, we're no longer getting points for neurological issues, and when we answer 1840 as issue with transferring. We no longer get points across the top on row 1 where we have blindness and low vision. Where the patient has blood disorders, we don't get any points for a first episode, where previously we got 2. We have cancer and selected neoplasms. We don't get anything for a first episode we don't get anything for a late episode with low therapy, but we get 8 points reduced from 10 for our neoplasm in row 3 and column 4 of each of these tables. So they've significantly reduced the number of points in many of the areas. If you look at how many dark red there are compared with dark green, it's a significant blow to home health agencies. In each of these rows, it's going to tell you what you get points for and what you used to get points for. So in row 1, primary or other diagnosis, so regardless of whether it's primary in M1020 or it's secondary in M1022, if it blindness or low vision, in 2014 you got 3 points if it was a equation model 1, you got 3 points if it's equation model 3, 3 points if it's 2, 3 points if it's equation model 3, and 3 points if it's equation model 4. So if a patient had blindness or one of the diagnosis codes that appeared in blindness and low vision group, you actually received 3 points all across the board. In 2015, you don't get any of those points. Blood disorders such as sepsis and such, you used to get 2 points in equation model 1 when it was an early episode with low therapy. You used to get 5 if it was an early episode and later high therapy. Now you get 6 points if it's a second episode, if it's an early episode with high therapy, and you get 3 points if it's a later episode with high therapy. You don't get any points if it's an early episode. Diabetes, you used to get 5 points for an early episode. You get no points for an early episode with low therapy. You get 13 points if it's a low episode with high therapy, but in 2015 you only get 8 points. So this is kind of how to read these. Go across in the row and be able to compare between the 2 years, but focus on the significant number of red as we go through these to help you understand. Some of these questions, like if you look at row 7, primary or other diagnosis equals to dysphagia. Well, dysphagia is a case mix diagnosis code, but your clinician must have answered in 1030 as option 3, therapy at home is internal. If they did not answer that question, then they did not get the case mix points. That actually went up, but you don't receive case mix points even if the patient has dysphagia and you answer 1030 as 1, 2, or 0. So when you're reading these, even though this may be a case mix diagnosis code, if you don't have other issues, you may not get the points. Now dysphagia, if you look above that on row 6, if dysphagia is your primary and or your other, and the primary or other diagnosis code is also a neuro 3 to a stroke, then you do get points. So as you're going through here, you'll get some points in some categories and not others. So it's important to be able to understand that. Sometimes they're grouping those with multiple diagnosis codes, sometimes, and those aren't necessarily manifestation codes, by the way. And other times you'll get a code that requires a certain answer in your OASIS questions. For example, your gastrointestinal disorders in row 9 has to have 1630 answered as a 1 or 2, or you don't get any points for row 9. So some of these cases are where a diagnosis code could be a combination code. For example, dysphagia due to a stroke, there is a 438 code that would be a single code for both of those. So then you could be able to get that code. So that could be your primary as a combination code. That's dysphagia and neuro 3 due to a stroke. But be aware that this is how to read this table. This is how the points are calculated. This is in row 14 through 24 of that same table. Continuing down, the diagnosis codes start at top, and the farther down we get down to just the OASIS-related questions. But you'll see a large number of these in red also. Most of these were due to the changes they did in the case mix diagnosis codes they removed. Several of the others are going to be changes in the answers options that they've given available. Following through here with case mix adjustment variables, this row 37 concludes the clinical questions that are available. for case mix points. As we get down to the bottom, we actually get more green than we have red, which is a good thing because green means they added points. For example, we get up to 33 points when we have a problematic pressure ulcer that's stage 3 or 4. If it's a earlier episode and we need high therapy, indicating the patient's more bedbound, they're more prone to sit and put pressure on that ulcer. Again, if they're a later episode, we can get up to 26 points, whether it's low or high therapy. So some of these at the very bottom did increase, others dramatically decreased. So that's the biggest factor of why agencies are losing money and why they're getting a 0 score, where before they used to have very high score. They'd have a C2 or they'd have a C3. As we continue to go down, here is the functional values. So row 38 through 45 of this table is where you gain your functional scores. So you can see there's some red and there's some green on this. 2030 in the very last row, 45, totally lost all case mix points for that, where it used to be possible to get from 0 to 3 points depending on the patient's status. These are your functional questions, exactly the same number of questions in 2014 that award points in 2015, but you get higher points or lower points. One of the things I do want to point out going back in these slides is if you look at a recertification of a later episode, which is a third or subsequent recertification and low therapy, which a lot of your patients may be, you're getting almost no points in this category. CMS is trying to let you know that they don't expect you to continue recerting your patient. Get in, do your job, treat them, and then get out. If they're no longer homebound, get out. If they continue to need services but no caregivers present, get an MSW in there. Suggest that maybe they go to a retirement home or a skilled nursing facility or something of that nature. But if you look at column 3, there's been a lot of calls that I've taken from clients that they're recertifying this patient and they're coming up with 0 points because you get 1 point if this was a neurodysphagia patient due to a stroke. You get 6 points if this patient has a brain disorder or other paralysis. Going down here continuing down, you get 1 to 8 points depending on some other cases, but you've lost a significant number of points for those. So where in the past they were a high-paying patient, CMS is kind of telling that we don't want you to continue recertifying patients. If you're in there for the 5th, 6th, 12th, 15th, I've seen some agencies in there for 19 visits or 19 episodes. That's far too long is what CMS is trying to dictate to you. So this is the functional scores. I think maybe I duplicated this. I apologize. That you'd have. This must be duplicated. Down here is your HHRG thresholds. This is the other component. One side determines the points, what we just looked at. This screen determines whether you're in a C1, C2, or C3, or an F1, F2, or F3. They also changed this. For example, if we look at the clinical, starting on the left, go to a C1 low, continue going towards the right, in 2014, what used to be a category 1 with low therapy was 0 to 4 points. We go all the way over to 2015, that is now worth 0 to 1 points. So it actually benefits the agency in one direction. It used to be that a C3 was 9 or more points. In 2015, 4 or more points is a C3. But keep in mind, a lot of those diagnosis codes that agencies have counted for in the past are no longer giving you points, giving you a 0 or a 1 range. Functional status, they've lost functionality here. And so F1, F2, F3 used to be 0 to 5 points for a F1. Now it's 0 to 14 points, and you're still in F1. It used to be 6 points in Category 1 or Equation 1 for an F2. Now it's 15 points. So you're seeing from this, hopefully, that there's a significant change in agencies that are recertifying patients and providing care for patients than what it used to be. The last domain, because you have C1 is your clinical through C3, those are going to be your wound-related questions, your diagnosis-related questions, and your ostomy and other skilled care questions. The functional domain F1 through F3 are going to be your ADL questions only. So you have your 1810 through 1860, I believe, are your case mix related questions. Your severity, shown on the bottom half of the screen, is a direct correlation to how many therapy visits you have in EM 2200. So you have an S1 through an S5, and you have exactly the same therapy levels as you had previously. So that's a benefit for the agency. They don't lose. Notice that this fifth equation, 20 plus, you're getting no extra points for severity or service domain. You're getting S1 regardless of what you had. And then your other points, depending on whether it's equation 2 or 4, will determine the points you get. So 0 to 7 is a C1 and so on. But in the previous table we looked at, when you have 20 plus therapy visits, it doesn't matter whether it's an early or late episode. It doesn't matter whether it's high or low therapy, because the 20 automatically says, hey, you're getting a certain number of points. So the way you determine this is if it's an early episode, you would go to column 2 or equation 2 to determine the points in the higher table. So let me go back here just to make sure you understand. So when there's 20 or more therapy visits, M110 will decide whether it's an early or late. It's automatically high therapy because you have 20 therapy visits. So it's either equation 2 that you're getting points from or column 4 that you're getting points from when it's 20 plus. But that's how you add up your points and how you get to where you're going. So let's cover OASIS and leave some time for some questions. OASIS has changed to an extent. There are some questions that are added. There are some questions that have been deleted. There's some word text changes, which is the majority of the changes. I would strongly encourage, if you don't already use the OASIS C guidance manual, visit this link, download it, use that as an in-service to train your nurses and help them understand how they're supposed to be answering questions. If they're truly trained at answering the questions, there is never a situation where they say, well, MUL 1860 could be a 3 or it could be a 2. If you follow the guidance in the guidance manual, you will either get a 2 or you will get a 3. There will not be a question. OASIS has been structured so that it's not subjective, it's objective based on what you see the patient do. And a lot of agencies now are going to have to make sure their agencies and their clinicians specifically are trained in OASIS to be able to make sure they're getting the best case mix scores possible. So by going through that, it was the newest one was released January 2015. Specifically, it was totally revamped because of OASIS C1. So review that, understand it, and filter that through. Do some in-services. Continue to integrate the quarterly Q&As. OASIS guidance changes or has a potential to change every single quarter. In let's see, April and July, I'm missing a month, October and, no, January. Sorry, I'm off by my months. January, April, July, and October, there's a new Q&A that comes out every single quarter addressing new items that you need to be aware of. So as you're going through that, be aware of what those are. Visit this website and download those each and every month because they give additional guidance that was not in the guidance manual. Questions that have been asked by nurses when they get out in the field. You yourself can generate a new Q&A if you email this bottom email address, cmsoasisquestions@oasisanswers.com. That is the agency contracted by CMS to be the clearinghouse or the source for the Q&As. If they cannot answer your OASIS-related question, they will pass that question on to CMS for further guidance. And in the next quarter, typically you'll have an answer to your question. Whether there's questions about face-to-face, whether there are questions about OASIS applicability, whether there's questions about a brand new situation of a surgical wound that is not answered in any of the guidance manual or the Q&As. So I strongly encourage you to eliminate the guesswork that your clinicians may be doing and you'll find this information out so that you can get it. So let's move on into 2 resources that you have available to you. Excuse me, your OASIS coordinators are coordinators for each of the 50 states. This may have changed slightly with the OASIS ASAP now that you're submitting nationally, but I have not read anything yet that indicates it has changed. But an OASIS coordinator is responsible for training agencies in that state for how to electronically submit your data, how to interpret the correction of errors on that data. So you'll get a final validation report or an initial validation report when you send in your OASIS, and the report is going to tell you there were problems with your OASIS, unless you're a great agency and you don't have problems. But in that, they'll have a cryptic number, a plus 256, or some other number with a plus sign usually. There is an OASIS manual that you can get off of a QTSO website that will explain that. You can also contact your OASIS coordinator and say, we don't have the faintest idea what this error means or how to go about correcting it. So some staff at Synergy have an understanding of that. Sometimes they get filtered to me because agencies don't know what that means. But your OASIS coordinator is really the one that can give you all of that information that you can rely on when it comes to a survey and other such. They support answers on the technical aspects of OASIS in the process of submitting that data, being able to capture the data electronically, and so on. The website at the very bottom gives you a PDF document. It word wraps, so make sure you join both of those lines together after the hyphen. But that'll be a list of the OASIS coordinators across the 50 continental states and territories that you can look at and know who to call, email address or phone number. OASIS educational coordinators are slightly different. These are the clinical people that can answer your questions. So they train on OASIS data set and administration of the assessment. If you have a question of, do I administer an assessment to this patient? How often do I need to? I have a patient that just came out of the hospital, and they came out of the hospital after my research, or whatever the case is. These are the people that can answer those questions with authority and be able to clearly dictate what needs to happen, and you can then rely on their answers in defense for a survey or another audit. They train on technical support on integrating the OASIS items into your clinical documentation. By now, OASIS has been out long enough, every agency should know that they have to do a comprehensive OASIS assessment. These people will train with you on how to integrate those OASIS questions. Can you reorder the questions in doing your own assessment? You don't have to buy forms from Briggs, you don't have to buy forms from MedPass and so on. You can create your own if you're in a paper world, and they'll be able to answer those questions. More importantly, for your clinicians to be able to call technical support on answering the questions on the clinical aspect of an OASIS. If your clinician truly doesn't know the OASIS guidance manual and they say, this could be a 2 or a 3, I want to make sure I get the best points for the agency, but I don't want to lie and have a survey discrepancy or an ADR or a cancellation of my claim, the OASIS educational coordinators is somebody they can call. They'll be able to rely on that answer because it's a CMS contracted staff member providing those answers. The website for those are listed at the very bottom of this slide. Again, it's word wrapped, so it would be far too small if I try to get it all in one line. You'll have to join those two lines together when you go out and get your educational coordinators. Let's cover some more of the OASIS C1, and then we can go towards concluding this webinar. SHP has a very good tool, the crosswalk that I've listed the website for, to be able to see the exact changes. They have an OASIS C form on the left-hand side of this document. They have an OASIS C1 form on the right side. And they have color coding so you can see what changed, what eliminated, what specific words were changed, and so on. You can also go to the CMS website. This webinar is really good if your clinicians already understand OASIS. It's about an hour and a half, I think. It's over an hour, but they go through each and every change, even if it's just a word. There's one question, which I didn't even list, that only a semicolon was added to the question in between OASIS C and OASIS C1, but they cover that. They cover the item intent and the response-specific instructions, so I'd highly encourage watching that as an in-service if you haven't already. It's free. Go through and watch it. There's a link for the handouts so you can download those and see as well. So let's jump into the OASIS C items. The OASIS C guidance manual has changed, so make sure you're using the OASIS C version, not OASIS C. OASIS C1 changed because of the need for grammatical and punctual changes, capitalization, changes in terminology. Some questions were removed. Some questions and time points were changed, and I'll show those. But for an example, 1307 would be an example, although that didn't change. That only appears on a discharge assessment. So the time points for some of those changed. The one specifically coming to mind now, the more I think about it, is 1350. That's no longer collected on a recertification or other follow-up, but that's in the slides I'm showing you. And then some questions were added brand new. So here's a list of questions that were removed. They no longer exist in either all of the assessments or at certain time points. So MU 1012, which was your surgical procedure codes, is no longer present in the OASIS C1 document. Your 1310, 12, and 14, your measurements of your pressure ulcers, are no longer found in an OASIS C1 document unless you've added areas in your comprehensive document to be able to collect those measurements. They're gone. MU 1350 was removed from a recert and another follow-up. They still do appear on the start of care and a resumption of care, SOC or ROC. They do not appear on a recert or other follow-up. 1410 and 2110 no longer appear on your discharge assessment, but they are still valid questions that appear on the other time points. 2440 was also removed from all assessments. So those are the questions they've removed, whether it's from all or part of the assessments. Here is the OASIS C1 questions where they added some new options in here. So these two questions have changes to the content fairly significantly. 1334, they removed in response 0. 1334 is a stasis ulcer that was fully epithelialized, or newly epithelialized, I'm sorry, and they said that those don't happen, was the direction from WOCN. So they took and removed that option. 1308 no longer has a column 2, which was very confusing for nurses when they were filling out column 1 and 2 on a recert or other follow-up. There's 3 or 4 slides here of question text that changed. I didn't list each and every question because I knew we wouldn't have time for those, but these are the specific questions where the text changed, and I listened to that webinar again this morning that I just encourage you to go to attend, and these are the questions that either the question itself changed or the answer changed in the text of the question. So these are questions your nurses and clinicians need to pay specific attention to as they're getting familiar with OASIS C1 so that they know how to mark the correct answers. I didn't bother, like I said, writing down all of the text changes. I started and then I found out it was going to be far too many slides to go through. So in here are the different questions, and whether it's a question text only, whether it's a question and answer text only, or whether it's just a question text. Make sure you focus on those questions in regard to the guidance manual that you download and be able to look at, because that's a significant number of questions. Some of the question text just changed from an EG to, for example, letting clinicians know that they can have more situations fall into that answer category than if they, because they didn't necessarily know what EG meant. But it means, for example, and they clarified that by spelling that out. Some other items were significant changes. So these are questions that replaced and renumbered questions that were not on OASIS C. This is now OASIS C1. For example, 1032 was replaced by 1033. Your immunization questions 1040 through 1045 were replaced by 1041 through 1055 to make them easier to understand. M2100 was changed to M2102 and has fairly significant changes too, also to be able to understand how that assistance is provided and what level is needed by your patients. 1309 is a brand new OASIS C1 question. It replaced the column 2 of 1308 and made it much easier to understand. 1309 documents the worsening of pressure ulcers while under your care. It's limited specifically to pressure ulcers, not stasis ulcers or diabetic ulcers. It's looking at whether basically this question identifies, and you want to make sure your nurses understand it, it identifies patients that developed a pressure ulcer during your care, because it's asking from the start of care or the most recent assessment that was done, do they have a new pressure ulcer? Do they have one that worsened, that went from stage 2 to stage 3 or stage 4? That's what this question. So make sure that you correctly answer this question, because this is going to bring extra scrutiny upon your agency if you say, yeah, we cared for this patient and they developed a stage 2 or a stage 3 pressure ulcer, or that one we admitted them with was a stage 2 and it's now a stage 3. So, I mean, obviously your documentation hopefully shows good teachings to the caregiver and the patient, since you don't have 100% control of the patient, and whether they follow your instruction to turn sufficiently and so on, but you're still held accountable that they got worse during your care. This is a wonderful tool that is in that webinar and the handouts for the CMS webinar that helps your clinicians understand how to answer the 1309 question. Since it's a brand new question, they break it down and they say current stage at discharge is the leftmost column. Look back to the most recent start of care or resumption of care and see if that pressure ulcer was present. And then if so, how to answer that. This is not looking and saying, well, was there a stage 2 pressure ulcer on the elbow that's now healed and my patient now has a stage 3 ulcer on the buttock? It's looking at that stage 2 that was present on the elbow. Is it now healed? And that stage 3 that's now on the buttock, was it present at the first start of care, to determine how you report that. So this is a great tool to be able to document that and be able to understand. I want to mention CT services. Obviously, OASIS is not new. Coding is not new. But a lot of agencies are getting a real big wake-up call that their previous level of coding and OASIS review may be insufficient. So I want to real quickly cover this, and then I'll open it up to questions and answers. Clinical questions and OASIS questions, the assessment of what we do as an outsourced service for agencies. We will review your assessments. We will do coding for you. We strongly feel that it improves the clinical accuracy of the agency. It also improves the quality of the coding and increases the reimbursement of the agency, even with the new changes to the PPS pay structure. There's a couple of quotes here. I won't bother to read because of the time involved. I want to leave some time for questions and answers. But these are two really nice quotes from long-term clients with Synergy CT services that strongly testify to how effective our process is, how much it's helped their agencies in doing their process. The need for this service is, are you concerned about audits? Are you concerned that your coding and your OASIS is not sufficient? Are your clinicians doing OASIS assessments? You're locking them and passing them on, assuming the clinicians know what to do? Or do you have an existing QA process in place? Are you looking for OASIS documents, and then when you go back for an ADR or you go back to review on research and you look at the previous start of care and you say, holy crud, how did we miss that item? Oh, Synergy's CT services can catch those items for you. We look at the full comprehensive assessment, not just your OASIS questions, and we make sure that those answer between the two of them. We have licensed clinicians that do the reviews. We have certified staff in OASIS and certified in coding. If they're not certified in one of those two areas, they don't do that portion of the service. We have an individual that is certified in OASIS, not certified in coding. She only does OASIS review. She does not do the coding. We have a certified individual that does coding come out of those cases. We review the entire comprehensive assessment. We look at your H&P. We look at your MD orders. Our focus is to make sure that the patient's situation is correctly reflected in that nurse's documentation. She's already spent, or he's already spent an hour, maybe an hour and a half with the patient doing the assessment. We want to make sure that that assessment documentation correctly reflects what they saw, and we present questions back to them. So we prevent loss of the dollars based on the case mix rules and the changes. We maximize your episode reimbursement, prevent upcoding or downcoding, and we increase your accuracy. The majority of clinicians in the field lack OASIS training. Majority of agencies get a new RN and they throw the documentation to them and say, here's an OASIS starter care, go see the patient and fill it out. They don't know that a surgical wound is considered a surgical wound by CMS for 30 days past epithelialization. So that's a case mix question. And if they say, oh, the wound's healed, it's scarred over, I don't need to do any further care, and they answer no surgical wound present, then your agency's at a deficiency because they didn't necessarily get the case mix points they could have. Another area that a lot of nurses are deficient in is answering your patients that have dialysis. CMS counts a dialysis shunt, AV access, in the patient as a surgical wound that is not healing. Most of your clinicians out in the field that we do reviews for will miss that until they're trained on that. They do not count that as a surgical wound. They say the patient has no surgical wounds, and as a result, they take and mark that no surgical wounds, and it results in a poor score on the agency and loss of reimbursement. Coding guidelines are very big. The Q&As take time to stay on track of. This gives you a chance to outsource your staff. It reduces benefit payments that an agency may have to pay. It eliminates concern about vacations and when people are going on vacation and work piling up. We make sure your agency is covered if you're a CT service client, regardless of the vacation staff of our staff. We make sure somebody's available to do your reviews. You avoid the training cost. I was talking about how significant ICD-10 is going to be to get prepared for. We take and train our CT staff to make sure they're aware of all the changes. You don't have those training costs if you're outsourcing staff, and it's a fixed cost, a fixed flat amount per assessment you have us review and or code, so you don't ever have to worry about going outside your budget. Clinical points, we have point of cares that are available, the web application, the DeVero if you're using that, eClinical I guess should have been removed, it's a dead product now, or if you're on paper, any of those are candidates for what we do. We review all the assessments or any combination of them, insurance companies and so on. You can ask me more questions if you have some, but I thank you very much for your time spent. The last thing I will say is to make sure you're aware that we have, and if you're not the person that makes those decisions, make sure your supervisor, your boss, your office administrator, your owner knows you can get the Healthcare Web Edition free if you're using our outsourced services. So regardless of what you're currently paying, if you're an agency that upgrades to the Healthcare Assistant Web Edition, you can get the software totally free of your normal monthly charges by using our outsourced services. There are 3 of them. CT Services, which does OASIS and review and coding. Billing Services, which does billing for you, resolves any issues with billing with your agency, post payments back into Synergy, as well as payroll and accounting services for your agency. If you're using 2 of those, you get a significant discount. If you're using all 3, you can have the software totally free every month you're using all 3 of those services. So it's a fantastic opportunity for agencies not only to save money on benefits, training costs, vacation headache and scheduling, but be able to get the Synergy software totally free. Hopefully it was very, very educational to you. Regardless of what I say, what you learned on this website, keep in mind you are held accountable to the documentation in the federal rule, the final rule information itself. I've given you my best to give you straight information and give you the sources to go to, but ultimately it is up to you guys to research and make sure that you're doing your documentation, your business practice in compliance with that. I guarantee you if you tell a surveyor or another auditor that Michael Tidd said to do this without being able to show them the source or the citation of why you're doing it, it won't benefit you at all. I love providing education and giving you instruction. Very few times did I give you my opinion without saying this is my opinion. Everything else came from the documentation. I thank you so much for being Synergy clients, working with us.